With atrial fibrillation, I think there's a lot happening in the field. One of the things which there's not a whole lot at the ESC, but I think which is getting a lot of momentum in the AFib community at large, is the impact of lifestyle modification in the treatment of atrial fibrillation. There is a lot of data coming out that patients who have a higher body mass index, who have sleep apnea, and who don't exercise enough have a high propensity to develop atrial fibrillation and can also have a much higher burden of atrial fibrillation. And if you treat some of these different factors through lifestyle modification, you can actually lower the burden of atrial fibrillation significantly. I think, there are reasons. There are each factor. For example, just to talk about exercise and sleep apnea, there are certain swings in the autonomic tone where the brain-heart connection can affect the heart and can, as a result of which, increase the irritability of the heart by these swings in the autonomic tone that can actually cause irritability of the atrium and result in atrial fibrillation. There are situations during sleep apnea where the oxygen levels can drop and again cause irritability of the atrium and can again cause atrial fibrillation. So there's a lot on the lifestyle modification. So there's the study called the BELIEF study, which I think came out from Texas in the United States. That's the primary center. And what that study is looking at is the additional value of left atrial appendage isolation over a conventional pulmonary vein isolation procedure in a persistent AFib patient and see whether that affects outcomes. I think we all recognize that in patients with persistent atrial fibrillation, there are many triggers for atrial fibrillation. They can come from the pulmonary veins, they can come from the posterior left atrium, it can come from the coronary sinus, it can come from the superior vena cava, and it can come from the vein of Marshall. So conventional practice for treating persistent atrial fibrillation is that you isolate the pulmonary veins with radiofrequency energy, usually radiofrequency energy, and then over and above that you then take care of the extra pulmonary vein trigger. So you ablate areas from other than the pulmonary veins that could be causing atrial fibrillation. This study is looking at is that beyond the conventional extrapulmonary trigger ablations, is there any added value of ablating and isolating the atrial appendage? The emphasis of this study is based on the hypothesis that the left atrial appendage itself can be a trigger for atrial fibrillation. And there's evidence that there are signals that come from the left atrial appendage that can set off atrial fibrillation, and there are smaller studies in the past that have shown that by isolating the left atrial appendage, you might actually do better. So this study is looking at a population of about 150 patients in a randomized fashion, which might help address this question. I think the study will give us some directions. Now, many of us have intermittently been doing left atrial appendage isolation, but don't do it conventionally because we are fearful of the fact that if you isolate the left atrial appendage, maybe you can make the left atrial appendage mechanically inert, so it has really no mechanical contraction, as a result of which they may be at a higher propensity to develop clot, and then they could have strokes from that. Now this study is looking at a 1-year follow-up, so even though it may look good at 1 year, and I don't know what the results are going to be, I don't know if it's going to give us the same results in a long-term follow-up, whether it impacts the incidence of stroke or other hard endpoints over a long-term period of time. So I think it's certainly a good step in the right direction, and I'm looking forward to seeing what the results on that front are.